this program was to really learn from the context that all of you work in. So palliative care, Dr. Raj, of course, is going to give you a much deeper introduction to it. But this is the first time we're conducting a volunteer training program virtually and outside of Kerala. We are very mindful of the fact that here in Kerala, we have access to a system that has long recognized palliative care as part and parcel of the healthcare system. And although we are far from being an ideal system, we are still a little bit ahead of the curve compared to the rest of the country. So while being mindful of that, we also wanted to be sensitive to the context that all of you work in. And as we go along, we have tried to make this as interactive series as possible. I'd also like to say that what we cover in the next 5 days is pretty much scratching the surface of what all the work entails. And we will be busting some myths as we go along and so on. But there are other programs that once you finish these 5 days with us, if you would like to sign up with other programs, depending on your backgrounds and what is appropriate to you, we will be happy to connect you to those programs as well. So that's just the context, the larger context that I wanted to set up before we go in. And I'm really grateful to Lakshmi, Dr. Raj, and all the other faculty who you're going to meet over the next few days, Babu, who's really the mastermind of this program from Trivandrum, for bringing us together. And you'll meet all of them in, you'll meet them all as we go along. So right now I will invite Dr. Raj, who I know is the reason most of you are here, to please take us through our first session, which is the introduction to palliative care. And towards the end, I'll come in with a little bit about palliative care in humanitarian crisis settings. All yours, Dr. Raj.
Thank you, Smriti. Thank you, Raju. Thank you, everybody. One of you during introduction said Namaskar. Namaskar really means I bow to the divine in you. I really think in this group, there is more God than you will see anywhere, including temples, churches, or mosques. If God is the essential goodness in the universe, it is available in plenty in each of you, which is why you are here. Compassion. Some people wanted to help others. So I am a doctor by training. I was trained as an anesthetist. I started treating people's pain, then found that people are more than nerves and pain. And I ended up working with the most amazing team in the world. I'm so grateful to have the opportunity to work with this team. And I'm glad many of you will be joining the team from wherever you are. I hope we will all together make a beginning which will change many people's lives, but equally importantly, change our lives. Many of you are well versed in palliative care. I saw Pranab Basu's name in the list of participants. I saw Rana Mitra, though they may not be here right at the moment. I see Amal Raj, who came to a palliative care training program maybe a decade back. Of course, as a parliamentary person, but so many people. Dr. Ashok Matthew, who has been working as a palliative care doctor for 10 years. So many people are here. I hope you are not disappointed, because we cannot ignore the people who are rather new. We have at least one high school student with us, Purnendu. People who are beginners. So we will have to cater to everybody. So the seniors, please bear with us if we go into the basics. And can I make one request? This is a serious matter. You agree that this is a serious matter? It's a serious matter because we are talking about getting into other people's lives. We are going to talk about the most intimate parts of other people's lives, and as activists, we are going to talk about things that will change the very core of their lives. Do you doubt that this is a serious matter? But in these electronic courses, there are some potential problems. Sorry to sound like your primary school headmaster, but this is one of the problems. It will ring. There will be WhatsApp messages coming in. We'll be tempted to look at it. So please do what I am doing. I have just put mine on airplane mode for the rest of the session. I am giving you a little time to do the same, or to take it away from there if you don't want to do it. Take it away. If it is there and a message comes in, it's superhuman temptation for many people. Please either put it on airplane mode or switch it off or take it away from you. And this, please try to do this all through the 5 sessions. Let us concentrate. We are going to talk about the most important things in our lives and in many other people's lives. Particularly to the experienced people here, what you may have heard when you were introduced to palliative care and what we now talk may be slightly different. Now we talk about palliative care. If somebody asks what is palliative care, we say it is prevention and management of serious health-related suffering. It is prevention also, prevention and management of serious health-related suffering. It is not only care of dying people. It is not only care of cancer or some diseases. It is not only care of people who are marginalized and free. It is not free treatment given to the poor alone. It is prevention and management of all serious health-related suffering. Unfortunately, that is something that should have been done by the medical system as a routine. Let me share with you this story. We just 2 years and some months back came across a family living in this thing. What do we call it? It looks very much like the chicken coop that we had in our backyard. In my childhood. A mother and child lived there. Or the mother and child were dying there. That's more appropriate. The woman had a diabetic foot, had been advised an amputation. But even that was not possible. Can you imagine? An amputation was not possible because there was no one as a bystander. Without that, nobody is welcome. Single parent of a 12-year-old boy because her husband had left. This was not in their own land. The chicken hoop was in her mother-in-law's property and she had allowed her to live there. When I met them, the story I got was that on a Saturday, they found themselves with no food at all. They lived on handouts. On the Sunday, the son said, "Mom, I can't bear this anymore. Let us kill ourselves." The woman said, "Hang on, son, some hope. Give me a day. Mom will find a way tomorrow." On Monday morning, the woman took the child to the primary health center. And fortunately, there was a kind doctor who would admit her without an adult bystander. She was admitted to the community health center, and there she had lived for 3 months, during which her diabetes could not be controlled. And how did they eat? One sweeper in the hospital, the lowest paid employee, every morning cooked food, brought it to them. And that's what they had for breakfast, lunch, and dinner. Can you help saying namaskaram to that person who herself was poor enough to be a sweeper in the hospital? This happens. Everybody in Trivandrum, you are allowed to hang your heads in shame because this was within the city of Trivandrum. This doesn't happen only in Trivandrum. This happens all over the country, and very often outside of Kerala, things can be even worse. These stories continue. Ladies and gentlemen, this is how the World Health Organization defines health. That it is not only absence of disease or infirmity, that it is physical, social, and mental well-being. People like this man with advanced cancer, or that mother and child at risk of losing a limb and losing their lives, are still treated only for diseases. The physical, social, and mental well-being then become a bit of a joke. Ladies and gentlemen, this is what we are all going to do together. Our numbers are growing. The palliative care movement is, as it happens, is more than 40 years old in this country. From its birth in Mumbai as Shanti Vedana Ashram, Southern, founded by Dr. Lucito D'Souza, it has been 41 years. We are still dealing with issues like this, and this will change. If we are all together, this will change. If only we realize what we are capable of, as Mahatma Gandhi said, that will suffice to solve most of the problems in the world. I will stop the screen share, and at this point of time, I will request a colleague to come in. Ashla, some of you who were early enough heard Ashla introduce herself. Raju, can I bring in Ashla? Can we be together here? Yes, thank you. Ashla introduced herself as a volunteer. At the age of 26 or 28 or something like that, Ashla fell from a moving train, broke the bone in her neck, and became paralyzed in all 4 limbs. She picked herself up. You see her sitting there. She is sitting on a wheelchair on which she is dependent on for her mobility. I would like you, Ashla, to tell the group a bit of your story. I'll ask a few questions. Some of them are very personal questions, and I quite realize that some of them you can answer. Some of them you may not be able to answer in full because it will concern others, it will concern very personal things. But I want to take you back to that horrible day. How many years back, Ashla? 10 years? When
almost
11 years. When you fell off that train, and in your own words, you were flying on moments, and you woke up 3 days later in a hospital. In that hospital, at that point of time, Ashla, can you tell us what exactly were the elements of your suffering? Let us start with your physical issues first. What formed? I know the doctors fixed your spine. I can even see the scar of a surgery there where your spine was fixed with possibly a steel rod. They took care of your fracture. But was all your physical suffering taken care of by the hospital?
My spinal cord injury got all the attention. So they fixed, as you said, they fixed my spine, and there were surgeons to look after. But no, not all. I still had pain, and nobody asked me whether I have pain. And I had constipation and other symptoms, but that wasn't taken care of. it was only my spinal cord which got all the attention.
Everybody here, please realize that 96% of Indians do not have access to basic pain management. I'm not talking about all palliative care, just pain management. If they are rolling in pain from an advanced cancer or a vascular disease or anything, or an injury like this, you do not get pain management. Only 4% of Indians or less get it. This is something that we all have to change, and over the next few days, you will all talk about how it can change, but we all have something to do. So that was the situation in which you found yourself, Ashla. Let me ask you, so they were taking care of your fracture and not you. Is that true for everybody? Was there any silver lining in somewhere?
That question reminds me of one nurse, like who actually went ahead beyond her duties to help me in the ICU when I was so desperate to read something, because that was the only way I could. I thought that will distract me, but I don't remember her name. I was too sick to remember her name. But she found a magazine from their rack, an old magazine, and brought a table next to my bedside, adjusted my coat so that I can read. I could not read much that day because I was so giddy and sick. But that one act that I'll never forget, what she did for me on that day.
You hear this? 11 years later, the greenest part of her memory about that time is an old magazine rack, a table being brought around, the bed being adjusted. That act of kindness, so powerful experience, Ashla. Thank you for sharing that, which tells us how much we are capable of doing if we truly care about somebody else. That brings me to the emotional well-being part of it. In those horrible days, what were your major emotional suffering, elements of emotional suffering? Say depression, anxiety, guilt, fear. What do you remember most?
I was depressed about depending others for my daily activities. I was, of course, anxious about the future. I didn't know what is going to happen, and I used to wake up every night screaming. So I'll have this feeling of falling down, but never actually reaching the ground. Now I know that it is called post-traumatic stress. Back then, I was so afraid. I didn't know what was happening to me.
Already, Ashla, already you have taught us such a lot. I started by defining healthcare, that is physical, social, and mental well-being, which is the duty of the healthcare system. And the healthcare system looks only at the spine and a steel rod. These were issues that mattered to you most. That was about physical aspects and emotional aspects. There must have been much more about emotional, but I don't want to delve too deep into your thoughts. But on the social front, you see, we are all social animals, right? We need our relationships just to exist. There may be an exceptional person who is comfortable only with one's own company. We are all social beings. And all of a sudden, all that changed, didn't it, Ashla? What exactly happened to your relationships? I know you cannot explain everything because it concerns others. There's only so much you can say out in public. But I'm asking this despite all this because we all need to learn about this.
Yes, of course, it did change. And what I could see was like some people I thought was so close disappeared from my life. But then at the same time, some people who whom I didn't have so much of connection, or I didn't feel that before, but they stepped in to help. They were there for me whenever I needed somebody. So that's what something which I noticed in general about relationships during that time.
I am sure a lot of people would say the same thing, and I have heard this time and again and again and again, that the persons closest to you sometimes, or you think are closest to you, have had a very superficial relationship, and either because they are afraid or they don't want to take the trouble, they just vanish. And people whom you never cared for so much just step in. Zaver, Smriti, is that not very familiar to all of us? And maybe why am I highlighting that? Maybe it's an opportunity to introspect about our own relationships. Look at what really matters. Maybe that Friday evening get-togethers, maybe they do not matter so much in your life except for a momentary pleasure. Thank you, Ashla. That was a very personal thing. But let me also ask you, the relationship issues, could it have been some that you created yourself because you did not want to burden others? You avoided, did you avoid some people?
Yes, of course I did too. Because I was so dependent and I didn't know how to handle myself. So I didn't want some of them to be part of my life at that point of time. Because I thought it's too much for them to.
Ashla, we have talked about your relationships, your emotional factors, your physical issues. What about now? I mean, like, I'm just by way of comparison. You said some of those relationships were not really serious. Some of them abandoned you, possibly. I use the word, that's not your word. But how did that change you as a social animal?
I think the way I looked at life changed, and then I started valuing things which I took for granted earlier. So yeah, that was something. The way I looked at life changed drastically.
Maybe this is relevant not only to someone with a spinal cord injury. This could be important to anybody getting into a serious health issue, whether it is short term or long term, all of a sudden. And particularly so very important in these COVID times. So you also talked about the relations, but how about the financial implications? All of a sudden, such expensive treatment and the hospital. And, I know that you stayed in a rehabilitation institution for a long period of time. What about the financial implication?
I was so fortunate at that front because I was working at the time of my accident and I got help from the company. They arranged money for my treatment, and my mother used all her savings to give me some good treatment. We were in no position to go back home because there was no physiotherapy available. So she made sure that we stay in hospital for more than 4 years so that I get some treatment.
But Ashla, so you were among the, I would say, among the fortunate minority,
of course.
despite all your issues, in that matter, in the financial aspect, because that was taken care of. Now that you are a palliative care provider, no longer a palliative care recipient person, it's a palliative care provider. What do you see around you as the financial implication of health issues?
I have seen many people who went into multi-generational debt due to treatment expenses. Like especially when they meet with an accident, they're taken to nearest private hospital, and by the time they get discharged from their acute treatment, everything is gone. The house, all like savings, everything is gone. Children comes out of school, there is nothing to eat. I've seen that in many families repeatedly.
Everybody, please take note. Do you know the number of people who are driven below poverty line by health expenditure in our country? If you don't know this, India is particularly bad. According to World Bank data, India is among the worst 12 countries as far as this destruction of families is concerned. And 55 million Indians, 5.5 crores of Indians are pushed below poverty line with catastrophic health expenditure. Why am I saying this? Do the volunteers, does the community have anything to do with it, Ashley? What do you think?
Yes, I think like we as a community has a responsibility to help our neighbors come out of this.
And that may not necessarily be by paying the bill in every corporate hospital. That may be by ensuring that people get rational treatment and not needless treatment. So I think these are all things that we need to be aware of. I'm going to share my screen again for a minute and show you what Ashla has told us so far. She has told us that when you encounter a serious health issue, the suffering may be in the physical aspect, like pain. Don't worry about it. Constipation, don't worry about it. These may be words you hear, but the healthcare system often does not do anything much about it. The social relationships, financial issues, the emotional issues. We haven't yet talked about the spiritual issues. But now I bring a question to the whole group. Please either speak up or put your answer in the chat box. What Ashla has described so far tells us of the magnitude of the needs of people for health, physical, social, and mental well-being, which currently the healthcare system is not doing. Maybe if you need to take a 30 seconds to think, what can each one of us do? What's our role in relieving this healthcare, the health-related suffering? Who is going to speak first or put up a chat comment first?
Hi, good evening, Dr. Rajagopal. Nilya
Good
this
evening.
side.
Who is speaking? May I know?
Nilya.
Okay, Nilya.
Yes.
Hi.
Hi. Great. So I think there are a lot of things we can do. So starting with first, truly, and I believe in this quote that the only person we can really change is ourselves. So first is very simply to care. Something that it should matter to us, right? It could be when I look at these four factors. Now in the age of digital media, I mean, digital is one thing we can all invest in. Raising funds, that's another. The third is also going on our own journey to get adept and equipped with skills to support not only our neighbors, just any person with concerns related to emotional health, spiritual health, social health, and go on this journey ourselves to be able to support others around us, which would mean, you know, getting your knowledge updated, reading, practicing, And then honestly, I think with a lot of authenticity, sitting and having that conversation with others around us. So that those would be some of my thoughts.
Nilia, that's precious. So many things you mentioned, like bringing that old magazine, right? Adjusting the bed so that Ashla could read.
Yeah.
See, being able to see what is the person suffering is and what is most important. Abhijit, you have your hand up.
My hand is
No,
up.
Abhijit.
Okay.
Yeah, actually, one of the questions that started bothering me from the time you started speaking, sir, was that palliative care is so important in our society, that this has to be an integral part of our society. It has to be seen in every structure of our society. And so, why is palliative care not? I mean, why is there not a palliative care department in each hospital? I'm sorry for asking this question now, but when it is so important, the volunteers will do this thing, but this is something that should be like a bill, like a government thing, where you should not have a hospital if there's no palliative care.
Abhijit,
Yeah,
Abhijit,
yeah,
we live in a democratic country. We rule ourselves. Abhijit, if it is not there, you are responsible.
okay.
Each one of us is responsible. If we had raised our voices, this is why it's so important, Abhijit, that we all should get together. Our voices need to come together. And unless there's a demand, the rulers are too busy. So, Abhijit,
Yeah,
very vitally important, this is the need. We
yeah,
need to make sure
yeah.
that people have access to palliative care. Now it is less than 4%. We have to get it across to 96 people. It may not, I'm sure it will not happen in my time. It may not even happen in your time, Abhijit, but we have to walk a few steps. Abhijit, you have brought up a very important thing.
Yeah,
We need to make this happen because this is only justice. Our constitution guarantees life with dignity. We have to make it happen. There are several comments on the chat box.
yeah,
Lakshmi says, listen to those who are in need. Listening, this is something that we can all do. That nurse who brought you the book, listen not only to your words, listen to your face, your eyes, your suffering. Listening to what is said and what is not said. Mr. Ramakrishnan, thank you. What are you saying? Sit with them, listen, identify all needs. Do what you can. I mean, I'm not exactly saying Mr. Ramakrishnan's words, but peer support and counseling, he says, but the first few words are the most significant. Sit there, listen, be there for the person, do what you can. And Amal Raj, social and emotional assistance can be ensured by consistent follow-up and by involving the family members and immediate community around them. Yes, absolutely. We will come to that community participation presently, Amal Raj, which is why you are there. And in Zaver Chowdhury, partly gives answer to Abhijit's comment. Advocacy. We all have to be advocates for people who are ill. Emotional care, love and support, Manju says. And Manju and everybody else, as Reverend Jeremy Jabaraj says, allocate and dedicate time. But yes, absolutely. And all to do this, as Manju says, provide love. Manju used a word that we don't usually use in medicine. I haven't seen any medical textbook where that is defined or recommended as a treatment protocol. Love. Just human love. So powerful. Ashla, really, that nurse who brought you the magazine gave you that. There are many more comments, and I'll come back to them. But before I do, let me come back to my screen share and point out something that you all have pointed out already. that if all these aspects are to be taken care of, the team should not only be doctors, nurses, and other professionals. People from the community need to come in, and we will talk more about it presently. Raju, can you do me a favor and show that 5-minute video clip where Smriti is giving a TEDx talk that must have been 20 minutes, and 5 minutes are stolen from there and presented here. Smriti is going to talk about the concept of total pain. That is all these four things together.
In palliative care, we have this notion of total pain, pain that takes into account the life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team that I was a part of was called in to see this fisherman in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by this stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding tube. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him, because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, he took this man's hand in his own, and he asked him, he said, "What's your biggest concern right now? What is bothering you?" What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own, and this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of children from disease-ravaged families that can no longer afford to send them to school. But this process takes about a week from when the child has been identified. In this case, however, we sped up the processes. Donors were found, pledges were made, documents were signed, all to see these 2 children, aged 8 and 10, through to college. We returned to the fisherman's house the next morning, and he was asked what his pain was. Still 6, he said. He was then shown the documents, and he was told, "It is done. Your children will not be fishermen." The transformation on that man's face was magical. And once he had digested that information, he was very gently asked one more time, "What is your pain now?" 1. He died 3 days later, pain-free. And that, my friends, is total pain. And that was when I truly learned my first lesson in being still and allowing.
Thank you, Smriti. I must have used that clip about 227 times so far, And I never ever get bored by those words. That is so precious. What Smriti demonstrated to you just now was how a man's emotional and social issues impacted his physical suffering. Pain is a physical symptom, you would think, though pain is defined as a sensory and emotional experience. His mental state was giving him a pain of grade 6 on a 0 to 10 score, and taking away the problem, the social issue, brought it down to 1. That was what happened. And sorry, can you see the screen?
Yes, sir, we can see
Okay.
you.
And I think without that magazine, old magazine brought to Ashla, healthcare was incomplete. Before the children's education being taken care of, healthcare is incomplete. If we leave 5.5 crores of Indians financially destroyed, what kind of healthcare are we giving? And this cannot be achieved. Now, at least, especially in a country where less than 2% of the GDP is spent on healthcare by the government alone, we all have to chip in. This is where the community has to come in. But I think I'll go back to Ashla. I have a few more questions to ask her. Ashla, we talked about the physical, psychological, and social suffering. Social in terms of relationships. In your case, not the financial, but you manage. But if I ask you, your connection with your universe, this universe, with your words, did that change?
I completely lost all of my connections. I didn't have anything to look up to.
You had lost your world.
Yes, I did.
Ashla, you have a world now, or have you stayed? Is it still lost?
I do. I do have a like wonderful world. And if I say that, okay, something, but I was living before my accident was like, I was just an ordinary person going on with life, not without much thought. But then when I reached palliative care and I started getting it and giving it, so I found my life again. I do so many meaningful things, and I think it's a privilege to listen to people when they are in their most vulnerable state of life, when they're going through their illness. So I find meaning in doing that.
Ashla, that's what Smriti also said in her TEDx talk, listening. And earlier, Mr. Ramakrishna and Lakshmi also had mentioned that in their chat boxes. Listening is the key. And Smriti was explaining the power of listening. And very often we are too busy to talk, busy talking like I am doing now, that there's hardly any time to listen to people. But thank you, that was powerful. And Ashla, I remember maybe 3 or 4 years back, you were addressing a 2,000 people gathering in an auditorium in Kochi. I remember you saying that if given a choice, you would like to walk again. But at the same time, it's equally true that your life in the first 25 or 27 years when you could walk carried less meaning than your life now. Would you like to expand on that? Why do you say that life is more meaningful?
I was simply living at that point of time, sir, like any other. I'm not sure like any other because I've seen so many students and young graduates working in the social sector and doing responsible things. But then for me, at that point of time, it was just like, okay, my work, my books, and then beaches in Chennai. That was it for me. But then when I met with this accident, I got some time and I started looking back and thinking about what was I doing with my life. And when I got an opportunity, I started looking ahead what I can do with my life. So the things which I took for granted changed, and it was no longer available over there. So I started looking at life in a different way, and I found that okay, there is so much which I should be doing, which I can do, and then there is no so much of meaning to it.
Ashla, about that meaning. You are a person living with a disability by definition now. By the way, ladies and gentlemen, she also, among several things, in addition to being trustee of Palliative India, she also serves as my executive assistant. She cannot use her fingers, she types with her knuckles. You have those disabilities. There are others with various things that make them more vulnerable in our society. Like Pavan described himself as a person who is LGBTQI. So when there are these vulnerabilities, how does the healthcare handle it now? Because you have been at the receiving end. And what should it be like? Ashla, the question to you is, the people who are vulnerable, do they get some equitable care or no?
I don't think so. I don't see it happening anywhere.
But that's, ladies and gentlemen, everybody here, is that something that we should be looking after together? Whether it is poverty or gender-based discrimination or a disability or a different sexual orientation, whatever is making people vulnerable should be our business. Because as members of a so-called cultured society, which claims to be cultured, we cannot just turn a blind eye to all that. Ashla, what you brought in was a spiritual element, related to meaning of life. Earlier, who was it? Was it Manju who mentioned love? And very often we associate spirituality only with God. True, a person may be connected to the world most importantly by God, maybe, or by religion. Those are very individual and personal things, but may not be. Ashla, you have seen this happening a lot. Attempted spiritual support by invoking God or religion, which is very often, which has a calming influence, very often is supportive, but not always. Have you ever come across that kind of thing?
I did, sir. Like for me, that my spiritual side or my connection was to find myself again and to be treated as a person, because I totally forgot who I was as a person before my accident. So it was for me to come back to that person, or to understand and regain that kind of a personality. That for me, that was my spirituality or my connection. But then I've seen it like, okay, like people coming to pray, and people coming to preach and all. I've seen that a lot also. But what I was looking at is somebody who cared me as a person, somebody who will listen to me, and somebody who will like kind of help me to become that whole person again. That was what I was expecting, or I needed at that point of time. I wasn't expecting anybody to do that, but that was what I needed. But maybe what I was given, nobody asked me what I need, kind of. I remember.
Thank you, Ashla. So, I mean, people are connected to this universe by different things. For many people, the connection is most with God and religion. And by helping them to reconnect when they feel disconnected, you will be helping people. But not for everybody. This is where so many people have mentioned about the power of listening. Pawan repeats that sentence about listening. Listening, and that's what Smriti mentioned too. By listening, you are acknowledging the person as a person. And that is so very important, that is something that for which very often healthcare professionals do not have the time, which is where I think we come in as volunteers. And listening, as Pawan says, not only to what is said, but also looking at the non-verbal cues. And Pallabji is talking about saying namaskar to the sweeper. The sweeper who fed that family for 3 months, all 3 meals. And she is some of the poorest people in the world. And how rich she is with what she could give. So, Ashla, you have brought in spirituality at a plane which could be at the level of God and religion, but which could be beyond, mostly with making life meaningful. From there, if I would take you to what the healthcare system could do, what more could, I mean, just in a few sentences say, what more could the healthcare system have done in the physical front when you had your accident? Ashla?
Okay, so you want me to talk about what they have done or what would have been?
What you would have liked them to do?
I would have liked them to see me as a person instead of a patient number in some bed having quadriplegia, of course. I would have liked them to ask me what is worrying me the most, or what am I going through. I would have wanted them to listen to me, of course.
Ashla, you would also agree that that means more involvement of the community in healthcare. This group here, this
Of
group
course.
of 40 people here becomes so frightfully important there.
Of course, sir. And
even
that nurse who helped me in the ICU and the physiotherapist, I had a physiotherapist who actually encouraged me to work again, asking me, "You are a computer professional, why don't you go back to your work?" So, and that gave me something to think about even. So they went beyond their duty to help me. So I think that is also like how a person can help, community can help.
People like Purnendu are here. Purnendu, did I get the name right? Correct.
Correct, sir.
Okay. People like Purnendu are here from the next generation, a high school student. See, there are all these compassionate people. Purnendu must be, to be here among all these old people. I mean, what all could she have done? She could have watched a movie on television. She's here. She has compassion in her. She has goodwill in her. Ashla, is that enough? To be a volunteer, to be effective as a voluntary healthcare worker, what more is necessary?
I think the training is more important, or very important, to be a volunteer. Because I've seen people actually coming to me wanting to help, but making comments which eventually hurt me, or I didn't want to, and then asking me questions wherein I didn't want to answer. So I've seen that a lot, and I think after coming here, I understand that, okay, training people can help a lot. If they get right kind of training, that can go a long way.
But okay, but we have good intentions, right? I mean, can we cause damage on the physical front?
Of course, if somebody comes and helps me to turn in my bed or shift me from bed to wheelchair without knowing how to do it, how to carry my catheter bag, then that's going to hurt me physically. And then some questions with very good intentions can hurt me and that can leave impressions in my mind for a long time. There are things which can go, and then if you, not just in my case, but if they go from one patient to another patient without washing their hands, it can spread the infection in that way. And then I've seen that many examples, and there are many examples wherein it can go wrong, sir, even the physical friend, not in social or psychological.
Thank you, Ashla, for bringing in the importance of
Physical.
training. Because we are all, professionals are trained in healthcare. They have their own problems of being too disease-oriented and organ-oriented and forgetting the person. We know that we are willing to look at the person, but we also need the training in the other part. And that's an important part, absolutely important. Thank you for mentioning that.
And one more thing which I feel so important is, sir, when you come to me when I am so distressed and not knowing what to do with my life, so I might be telling you something which is so confidential and which I may not want others to know. So if you can't keep it with yourself, if you don't understand the importance of keeping that to yourself, then that's going to change my life or destroy my life. So that is also something which is very important to understand, to keep the confidentiality. What all we need to be careful when we talk to people.
Thank you, Ashla. I mean, that is not only for the volunteers, for all healthcare professionals. Confidentiality is so important. And in my little over quarter of a century in palliative care, I have repeatedly seen how thoughtless comments hurt people, how well-intentioned volunteers hurt people, how thoughtless doctors break confidentiality and destroy families. All this I have seen. So thank you for those powerful lessons. And I think I'll go to the next bit. One of the things that you brought in terms of, where you brought in the connection with the universe. And I thought I would add these points. Connection is rebuilt when companionship is given to a lonely person. 2 or 3 of you mentioned looking after your aged patients, elderly people. Very often they have all their physical needs satisfied, but we are all busy. And companionship is something that we may not be able to give. Maybe you are, but we should keep pointing out to the families without sounding big brotherly, that companionship is very important for them. Because I see a lot of lonely elders and lonely sick people being totally lonely within a household with a large number of people, because they are just left alone. They are fed, their physical needs are taken care of, but they don't get companionship. And respect, treatment with respect, not offending dignity. At least one person in the introduction said how dignity was offended. And that's so common in the healthcare system. And most importantly, with your eyes and face, convey, I care for you. All this is part of spiritual care. And being non-judgmental. Being non-judgmental is so important. Saying things like, unfortunately, you smoked all those years. What do you achieve by pointing out that he had smoked as a young man and that you brought it on yourself? How does it help him? And wait, she's a troublemaker. She's kicking up problems. Those things we think, and that offends us. And if somebody has had a very bad history in his or her life, are you able to see my screen?
No, sir.
If somebody has had a very bad history, maybe as a wife beater, somebody who beat up even his wife and children, or somebody who was, sorry, let me just put this screen on first, or always drunkard and nobody wanted him, I would keep telling myself, it's all the more important that I should care for him. I hope each one of us will take that lesson. That for the person who has led a bad life by our standards, let us remember that we may be the only ones who care for him. Nobody else does. Their family may not, their community may not. Therefore, it's all the more important that we are able to be non-judgmental to them and care for them. And while I acknowledge that religion can be a powerful pillar of support, and I've repeatedly come across people say, it's his hands, it is his desire, I surrender to his wishes. That's a huge strength. At the same time, remember that at least transiently and sometimes longer, some people will feel rejected by God. My God has deserted me. Why? I led a good life. I always help people when people needed me. And he does this to me. What kind of God is this? You may be tempted to say, look, you shouldn't say things like that. That is sinful. Don't say things like that. And that only reinforces guilt. You don't achieve anything by arguing with that person. Instead, several people here told you this. Mr. Ramakrishnan did, Pavan did, Lakshmi did. Listen to that person with love, non-judgmental, and walk with him at his pace. And again, time and again, this actually was told by one of my patients to one of the volunteers. He said something like, translated, Betty, I thought my God had deserted me. He has not. He sent you to me. And that is a huge achievement on the part of that volunteer. Before I ask questions, I just want to bring up fairly quickly what we envision, what I hope you will share this vision. An India in which palliative care is integrated in all healthcare, so that every person has access to effective pain relief and quality palliative care, along with disease-specific treatment, not after the treatment, not when the person is dying, along with the disease of treatment, across the continuum of care from the beginning to the end. Integrated in the healthcare. Advocacy. We have to work together to make this happen. So, Zohair, you mentioned advocacy, and that's our collective job. I also hope you will agree with the core values that we have listed out. I am chairing Palliative India, but I have failed if I consider Palliative India more important than the person. My colleagues and I need to keep reminding ourselves that the commitment to an organization should be secondary to commitment to the person and the family, primarily. Because as our structures increase, as our growth, as our organization gets stronger, the interest of the organization may sometimes supersede that of the patient, and that will be a tragedy. Secondly, we will recognize that care is the right of the patient and family, and we stand committed to giving it to them. Care is not a charity that we give them. Ashla, you once said that being told this was strengthening. What did you mean?
I've always felt like a burden to my family and society when I had to depend on others for all my activities. So, and while I was sitting in our office together, you helped me with many like small things, like keeping my leg back to my wheelchair foot stand when it went out of place. And also I didn't, and you told me that it is your, you're doing, you're not doing me a help. It is your responsibility to do it. But it took me so long to digest that. But then that relieved a lot of stress when I finally understood that, okay, this is something which I receive as a person in this society, and there is a right for me to have this kind of care when I really need it. So that was a relief for me.
Thank you, Ashla. You may not be able to claim that right and demand that right because the society, if it doesn't accept that responsibility, we cannot.
No,
And the
sir.
third core value is compassionate and competent care. Not just anything that you can give. Competent care, recognizing, valuing human dignity is at the very heart of what we do and why we exist. We shall endeavor to do the right thing for the right reason as best as we can. And we recognize the strength of the social capital being the essence of goodness in the community, and shall engage in a partnership with the community, enlisting the support of volunteers and other community entities, creating the capacity to meet community needs. And I'll go say a few more words about that. We have to remember that this is in the context of the dwindling family structures, migrant laborers going out to work, small nuclear families being left alone, small hospitals closing down, huge multi-crore projects, corporate hospitals and government structures be growing, and these people be feeling strangers there. Everyone here forms the meso element of the social capital. Zaver, Amalraj, Lakshmi, Purnendu, Ashla, each one of us forms the members of the community who connect the healthcare structure to the microscopic element of the family. Next, we shall treat everyone with respect. This is not negotiable. Remembering that every individual is superior to each one of us in some way. Of the 41 people who are attending this session, I know that each one of the 40, one I suppose is myself, each one of the 40 is superior to me in some way or other. And I have to keep reminding myself that so that I can treat everyone with respect. And we shall embrace the ethical principles of autonomy, that is the person's right over oneself, beneficence, doing good and not doing harm. That's not beneficence. And justice, fair allocation of available resources, all exercising them to the best interest of those we care for. All these are core values which we have accepted, and we have accepted our responsibility to get healthcare system to people where they are, not only sitting in our ivory towers. That means this is Dr. Amrita, and I think that is Ashwati. They had a lot of climbing to do to get to that house. But reaching them where they are is our responsibility. Any responsible healthcare system should reach people where they are. We are not yet able to reach them whenever they need us, but that's what we will aim for. For every one of us from today is certainly a healthcare worker, if not a professional. And this is what we'll aim for. And what does all that, where does all that get us? That mother and child, the child who wanted to commit suicide, eventually found us. So many people did so many things. One lawyer in Trivandrum, Sandhya, whom I consider God, another God. Sandhya put up a Facebook post. Money came in. They now have a rented house to live in. We have been trying to get them a place of their own. We haven't succeeded. A compassionate endocrinologist took over the control of her diabetes, treated her limb, which was once we suspected that it may have to be amputated. But as you can see, the mother and son are walking again. They are rebuilding a life. It has been more than 2 years. She is not completely out of it yet. She will never be. She has been a diabetic for nearly 37 years. And she will continue to need medical management. But giving them this amount of quality, building that to this level, is a work that we did together between professionals and the community. The community doing more than what we professionals could do. And I stop there, ladies and gentlemen. Smriti is coming next. Smriti, I know you will have quite a lot to say, and maybe we should postpone further audience participation. I'm glad some participation happened already. Further audience participation. To you all, Ashok Matthew asked me to share the core values. Ashok, very simple. Just go to Palliative India website, palliaveindia.org, not com, org, and go to About Us page, and it is given there. Mary has added one more comment. The doctor held the fisherman's hands. No words were used, but sat there patiently. People in intense suffering take time to collect their thoughts. And as Bharti says, hospital wards can be made more cheerful. We should look after our own institution a little more and change the paint possibly. We could be more cheerful. Death should not be treated as a taboo, but as part of life. Thank you. Smriti, I'll stop there and I'll leave it to you to continue. And if we have 5 minutes then to take more questions, we can. Thank you. Thank you, everybody. I'm staying here and listening to this.
Thank you, Dr. Raj, and thank you, Ashla, for such a soulful demonstration of what palliative care really is. I don't think this could have been demonstrated any better than the two of you have just done. I have a little bit to share, so I will try and make this quick and painless. My role today is to take you through why and how palliative care is relevant in a pandemic setting. So we recognize also that a lot of people, up until they're actually immersed in an interactive training session, go by the assumption that palliative care is for advanced illnesses or only terminal illnesses, and its relevance comes in only when somebody is suffering from something like cancer or some other illness that is past its treatment stage. Dr. Raj has so beautifully illustrated that that's not true, and palliative care really extends to all serious health-related suffering. Now, many people wonder what role palliative care can have in a pandemic setting, which is pretty much a humanitarian crisis. And the one that we are now facing in India, I think we'll all agree, is of massive proportions, the like that even the rest of the world has not seen. So there is a role for palliative care here. I'm going to take you through some of the key elements of that. And like Dr. Raj said, we'll try and take some questions towards the end, or at least invite some comments from all of you. So just to sort of firstly reiterate what palliative care is, that Dr. Raj has already talked about. It is active holistic care of individuals, and I'm going to add to that families as well, of all ages with serious health-related suffering due to severe illness, and especially those near the end of life. So if you see that diagram, you'll notice that it can begin right at diagnosis or even the suspicion of a disease, and then it comes into sharper focus towards the end, where we over time either exhaust treatment options, or the person through a process of shared decision making, which is something that palliative care strongly advocates for. And then it comes into sharper focus. Unfortunately, worldwide, especially in India, it is considered to be mostly end of life care. That's because the referral system kicks in so late, if it does at all. And that's one of the problems. One of you has flagged it, saying, why is it not part of every single healthcare system? And yes, why is it not? So that's why all of you are here, to be part of the change and to change that scenario. And it aims to improve the quality of life of patients, their families, and caregivers. So this was something that was again reiterated in the Journal of Pain and Symptom Management in 2020. So right now, we are all working in the context of a global pandemic. Whether we choose to or not, our lives are defined by it. And whatever it is that we aim to do in this time, we'll have to work within the framework of the larger pandemic that we're facing. Now, the work around understanding how palliative care fits into a humanitarian crisis is actually not new. It's been around for a while. There are organizations like PALCHASE, which is Palliative Care in Humanitarian Aid and Situations and Emergencies. And also there are WHO guidelines, and there has been a lot of work that was done to integrate holistic care for chronic diseases within governments and healthcare systems, which were outlined in these WHO guidelines, as well as in SPHERE documentation. The SPHERE handbook is basically a handbook that is created to, what are the different appropriate responses to a disaster. And disasters are both natural as well as man-made, as well as the kind of disaster that we're seeing unfold before our eyes right now. So it's not that the role of palliative care is new, it's just that now we are all part of it. And now there is a very specified role for it. And there was work that was done by palliative care agencies during the Nepal earthquake. There was work done during the Rohingya crisis, during the South Sudanese crisis, as well as during the Kerala and Assam floods in 2018 and 2019. And we were part of that response in Kerala. And there was a lot of good work that went into palliative care coming in as a humanitarian response to a crisis. But the current tsunami of suffering that we're seeing, and it has been described as a tsunami of suffering, and you can find this article, we'll share it with you. It appeared in the Lancet, and these are colleagues of ours who authored this. And what they also identified that the key areas where palliative care interventions can play a very strong role in a humanitarian crisis of COVID-19. Firstly, of course, is communication and goals of care. We in the palliative care community have always laid a tremendous amount of emphasis on empathetic communication, like Dr. Raj was talking about, listening with empathy, but also effectively communicating with our patients and their families. And in the early part of the pandemic last year in 2020, a lot of the really traumatic stories we were hearing coming out of the healthcare fraternity was from doctors, nurses, and healthcare workers who did not know how to have these conversations with people who were experiencing such tremendous suffering. No one has ever trained them to have the vocabulary to talk about end-of-life care, or especially in the case of COVID, where it's so rapid. The onset is rapid, the trajectory is so rapid, and the death is so sudden. And the scale at which this was happening, even today, a lot of healthcare workers are experiencing secondary trauma because they're so helpless in the face of this, and they simply don't know what to say and how to communicate. And how do we identify what the goals of care should be? That is, again, something that has been intrinsic to the palliative care methodology, to explore with people. What are your goals of care? What would you like? What is important to you? And these are, again, things that, especially in the Indian context, have never been taught at a formal level. And that's something that palliative care pays a lot of close attention to. Symptom control, especially those not receiving ventilator support. And symptom control, a lot of the constellation of symptoms that you see in COVID-19 map very closely to the symptoms that we have seen to a large extent: breathlessness, delirium, agitation. Those kind of symptoms that we're seeing emerging faster and faster in COVID-19 are something that we're not altogether unfamiliar with in palliative care. So that was recognized as a major area that palliative care could contribute. Psychosocial and spiritual care, of course. that the person is beyond the disease. There is a whole ecosystem around the person that needs to be cared for at a time of serious illness and suffering. And end-of-life care, of course, and staff support. Staff support is something that we're seeing as a huge problem at the moment, where because the health systems are just crumbling all around us. So there is a very strong case to be made for the relevance of palliative care in the pandemic situation in particular that we're experiencing right now. It was actually in the 73rd World Health Assembly last year, palliative care was actually recognized as a response to the COVID crisis. And the World Health Assembly also included a directive to include palliative care, particularly focusing on vulnerable groups, such as those with pre-existing health conditions, older persons, and frontline healthcare workers and other frontline workers. And it directed that governments must pay particular attention to the protection of these people. Now, that is one thing that has taken a tremendous hit in our country and everywhere else also, that with everything being so geared to taking, to responding to the COVID crisis, people with serious health conditions, pre-existing conditions, are being marginalized further. Now, an elderly person living alone with several comorbidities during a lockdown is at the intersection of so much suffering. They cannot even go out and get their medicines. They may not even be able to go out and get their groceries. And what happens in a situation like that? Last year, we put out a call for assistance from people between the ages of 20 and 40 who had their own vehicles, asking them to come and volunteer with us. And in a matter of 24 hours, 87 people signed up. And they went through a quick training with us. And these were the people who actually helped us bridge the gap to reach all these people who our healthcare, our home care teams couldn't reach. Simple things like delivering insulin to somebody who has diabetes and is unable to get out. Manageable conditions like diabetes were spinning into life-threatening conditions because people were not getting their medication on time. People couldn't go to, diagnostic clinics to get their blood drawn, to get their, blood work done. So we had 2 lab technicians who signed up with us, and they actually went ahead and got this done for them, probably intervening in life-saving ways for those people. And of course, we had a whole bunch of students, a group of students from a coastal community who really became the hands and feet and eyes for us. And there was a nurse who was identified within that critical containment zone who went on to every household, and she was given some palliative care training, and then she was able to take care of those people who couldn't get out of a critical containment zone. So these are the people who also get marginalized at a time of crisis of this scale. And they very easily and very quickly become invisible. So in palliative care, we have a very strong emphasis on identifying and addressing the needs of the invisible patients. And very often they're people who are not the primary patient. It could be the caregiver. It could be a child in that home. It could be somebody who's, a young daughter-in-law whose only job around the clock is to look after a sick person and has no other life beyond it. The carer of somebody who has a spinal cord trauma and also is completely dependent on the caregiver. So all of these different cohorts of people come into much sharper focus at a time of a pandemic. And that is why the relevance of palliative care becomes that much more critical. So here are some examples of vulnerable groups. Okay, Rohingya refugee children that we've seen in, coming across from Myanmar. Prisoners in Latin America. The prisoners community is also very, very marginalized at a time like this. And we're hearing of horrific stories of, their needs going unaddressed, people getting infected in prisons, a widespread infection. And of course, because they're prisoners, and like Dr. Raj said, our care has to be unconditional. Just because somebody has committed a crime does not mean that they should be relegated to that sort of suffering, and they don't deserve the kind of attention and care that the rest of us get. This is from Nepal. I mean, we all know of horrific images from India as well of migrant workers trying to make their way back home last year. And those images have not changed very much. I mean, of course, there are some other safeguards in place, but we're still seeing a tremendous amount of suffering even on that front in India as well. And here you'll see that this is people in South Sudan queuing up These are refugees from the South Sudanese camps, showing what it is like to manage social distancing. So even in a refugee camp, it's quite amazing that social distancing was practiced. All kinds of safety measures were brought in, and they were being very adherent to these sort of norms. And this is a time when we need to be mindful that while there are people who are infected by COVID, everybody else is also affected by COVID. And palliative care has a very strong role to play in all of those scenarios as well. And what we also see side by side with the suffering is compassion and acts of extreme compassion. And that is something that I'm really proud of the civil society and community groups and volunteer groups in our country today, that they're rising up to stand up for their fellow human beings. And this is an example that I'm sure people are familiar with from whichever part of the country that you're from right now. So at the worst of times, the best of humanity also emerges. And with a little bit of streamlining and training, I think we can make our contribution to society a lot more effective. What we are seeing now, I mean, these are quotes that are coming up in different publications. And one of them is that all doctors are palliative care doctors now. Why is that? Because today, every healthcare worker is struggling to offer solace, preserve dignity, as one of you said, and minister to the distress of patients, even as we share our patients' existential uncertainty about what the disease might have in store for them and our shared communities. So at a time of deep crisis and deep grief, this is being revealed, that there is a strong need for solace, dignity, and addressing distress. And it is also time for us to align our care with patients' values and priorities. Now, palliative care makes room for a very, very important tenet, and that is of shared decision-making, where we recognize that the person who is the recipient of our care is as much, a part of the decision-making unit. And the thing is, when somebody has a diagnosis of a serious illness, very often from that moment on, inadvertently, we strip them of their autonomy. They no longer are a patient, a person, they become a patient. And we see this happening in our own families. Someone who you care about a lot, your parent, a sibling who was a very, very capable person, the minute they are diagnosed with a serious illness, irrespective of whether the illness has progressed to a point of making them immobile or debilitated, we start treating them like patients. We start doing things for them that they can do for themselves, with all very good intention. But what we're really doing is stripping them of their autonomy. So it is very important for us to remember that no matter where they are in their disease trajectory, unless it's an illness that has caused severe neurological deficits or cognitive impairments or whatever, everyone has a right to be part of the shared decision-making process. And we need to align ourselves with their values and not be paternalistic about what we think is good for them, but what they feel is what they need. And we need to synthesize this with our prognostic judgment and give them candid and heartfelt clinical recommendations that never assume that one size fits all. So these are quotes that have come up during the pandemic from within the healthcare system. Someone talked about bearing witness. Listening is an act of bearing witness. And sometimes in the face of such adversity and so much uncertainty, where we don't even have time to have those conversations with people, they get whisked off to a hospital, they seem to have mild symptoms, and that's the last we see of them. Bearing witness is a very, very important thing, because to all of us as human beings, we like to imagine that our lives meant something, even though if it is suddenly stripped away. And nobody plans, we all have plans. We all have plans for our lives. We all have dreams and aspirations and things. But a pandemic like this one strips us of that, of those dreams. And very often, like we were talking about it, some colleagues and all of us at some point, where we said, right now we don't even know how many of us will be around 3 months from now. And it is no longer a pandemic that is impacting only people with comorbidities or only people of a certain age group. It's affecting everybody now. So bearing witness to one another in our own small ways is an act of intense compassion. And that is something that we all can do anytime, anywhere. And it's not just about treatment. We also need to make sure that our patients feel seen, that we see them as people. So one of the nicest bits of literature I came across while talking about grief and bereavement at the time of the pandemic is to, as a healthcare worker, to ask the family member on the other side of the phone. I mean, we are now the bridges between family members and the patient who's who's being treated. And what can you do? You can ask that family member, tell me something about your father that you'd like me to know. It's a very simple question. But it allows that person to think of something important that might be important to them, that might be important to that person on the other side, as well as it allows them to sense empathy from us. And sometimes that's all we can do. We may not be able to save that person's life, but if I'm able to ask that question and drive home the fact that, yes, I do see your father, not just as a case number, but as somebody who is someone, that is a feeling that will stay with the person that you speak with. So these are just some learnings from people in the healthcare community from the last year. Of course, there are emotional factors that are impacted by the pandemic, which I've just listed a few. I'm sure that particular slide can be populated by all of you. There is fear. Obviously, we're all living with a little bit of fear about, little or lot of fear about what's going to happen to us, to our loved ones. Some of us are separated from our families, so we don't know, what's going to happen to them. There's a lot of guilt that a lot of people are experiencing at not being able to do enough. Of course, there's a lot of anger directed at all kinds of different institutions and people in our country. There's a tremendous amount of anxiety. I think that is everybody's default setting now, whether we admit it or not. Everybody's anxious to varying degrees. There are higher cases of depression, obviously, there are several factors contributing to that, of course. There's anticipatory grief, the grief that we feel in anticipation of losing something. And there's a lot of that as well. There's complicated grief. Complicated grief arises in situations where the normal process of grief is hampered or derailed by the circumstances that are currently in existence. And I'm sure, I'm trained as a psychologist, and I can tell you that we're in for a pandemic of complicated grief because we are not finding closure. We're not being able to deal with the magnitude of the grief around us. And there's definitely going to be a lot of complicated grief around. And I can also tell you for a fact that a lot of people are experiencing what is known as survivor's guilt. How did I survive this and my family member didn't? A lot of NRIs are experiencing survivor guilt because they, especially those who are in countries with better healthcare systems or better safeguards in place and are not being able to travel back to India to look after especially elderly parents or vulnerable people at home. There's a lot of survivor's guilt that is going around, and that is something that all of us within India also can feel. So those are some emotional factors that are in play at the moment. There are social factors. Now, if you remember the Venn diagram that Dr. Raj shared, suffering and its components have various intersecting spheres, and the social factor is a tremendous one. Separation from family, unfinished business, not being able to crystallize our plans, the stigma and discrimination that a lot of people are experiencing, including healthcare workers who are not being able to go back home for months on end, or when they do go back home are being treated with suspicion by their communities or their neighbors. There is a tremendous loss of livelihood all around. Their savings are being depleted because people are not being able to go to work. Opportunities are being lost. People who are geared to go to college this year, people who are meant to do something this year, and it all has been derailed. Even young children who are being deprived of the opportunity to interact with other young children, which is such an important part of socialization. And there's a huge impact on education, like I just mentioned. So all of these are factors that we in palliative care have been mindful of also right through our journeys. And it has now become a much more prominent set of factors that we need to pay attention to. I won't go into too much on the spiritual factors. Ashla highlighted a few really, really important points, and that was, Dr. Raj took you through that discussion. But in the pandemic, of course, there is an added sense of existential anxiety and spiritual anxiety because there's a loss of meaning. After a while, people look around and say, what is the meaning of all of this? What is happening? And, I can't make sense of what is going on around me. And it could be something you see on the news. It could be something that you have experienced. Nothing makes sense anymore. A lot of people go the other way, and from feeling intense pain, just become numb. And we're hearing that a lot as well. And numbness is a symptom of that sort of spiritual anguish as well. People's faith is being challenged at the moment. Rituals of mourning are being cut short or just completely absent. We're seeing horrific imagery of, burials and cremations and all of that from across our country. And some of that is very, very heartrending and disturbing, because we're not being able to even perform the rituals that are so important to us as families or as communities. And we're disconnected from all that is familiar. We don't know if we'll ever be able to, travel freely. We don't know if we're ever going to be able to interact with one another. And one of the deepest needs a human being has is that of connection. We are a very tactile species. We demonstrate affection and love through touch, most of us. And when that is taken away, it has a very, very heavy cost associated also with the spirituality of that person. And many people, including a lot of doctors, I've heard a lot of critical care doctors and a lot of frontline doctors say that they've lost their purpose of life and sense of future. They don't know, I've heard way too many doctors say right now, why am I even doing this? I'm not being able to help anybody. Doctors are burnt out. They don't see the purpose of being in the medical field anymore. And that is something not just doctors are experiencing, but across the board. And the legacy angle. People are being deprived of a legacy. And legacy, again, is something we will talk about later in the coming days. Legacy is also deeply tied with the sense of dignity of a person. And so we'll get into that in a little bit more detail as we go down the series of talks that we have lined up for you over the next few days. Some of you might be familiar with the word triage. Triage means, allocation of available resources in an emergency healthcare setting. Who gets access to what? Who gets access to a ventilator? Who gets access to oxygen? Who gets access to medicine? And this is an ethical dilemma that the healthcare system is constantly having to face at an epic scale at this point in time. And again, goals of care. People don't know how to talk about what goals of care are. What would your father like? What would he have liked? Has he said anything to you about life prolonging or life support? Is it something he would have wanted? So those are conversations, again, that a lot of people are not trained in. And it's really sad, because at this point in time, young doctors who have still not finished their medical education are being called to the front lines. And they're being asked to do things that experienced doctors would find absolutely intimidating. So there's a lot of that happening as well. I'm just going to skip this slide because that's something that will take a little bit more time. But rational end of life care. This is a quote from the ICMR, the Indian Council of Medical Research, where they said that the duty of a doctor is to alleviate suffering. It is to cure sometimes, relieve often, and to comfort always. And there exist no exceptions to this rule. This particular statement is a very powerful one, because it reminds us of what it is that we're here to do. But in the context of a pandemic, we are being deprived of that time. We don't have time to sit down with patients and their families and to talk about shared decision making, to talk about advanced care planning. And symptom control can be focused on comfort. But at this point in time, because of the deluge of information that's out there, I'm sure each and every one of you every day goes through a few moments in the day where you don't know what information to believe, because there is no alignment in what is being constantly churned out. There is something called the psychology of a pandemic, which talks about those who are very paranoid and extremely cautious, or people, there's a continuing, and there are people who are, they don't really care, or they appear not to care, or some people who actually outright believe that the whole thing is a conspiracy. Now, ideally, at a time of a crisis like the pandemic, it would be great if three institutions align themselves, that is governance, media, and scientists. And when I say scientists, I also mean the medical scientists and the medical carers. But what we're seeing now is it's very rarely that the three of them align themselves. So what the media is saying sometimes is very divergent from what the scientists are saying, which is very divergent from what the policy or the decision makers or the leaders are saying. And at a time like that, that's also something that causes a deep sense of distrust within the community or in a person's mind. So you really don't know what to believe. And so I see a lot of these WhatsApp messages bouncing around saying, hey, this is a new guideline. What do you think of this? Hey, this is a new thing about this drug. Hey, this is. So if we actually had an aligned, coherent message coming from three of the most important institutions, I think we would be in a better place. But unfortunately, in the absence of that, we are left to our own devices and judgment. But what really could play a major role is continuing to care for the family and the community. And that's where people like you, all of you who have signed up for this program, become so critical to bridging the gap. And with a little bit of training or with a little bit of exposure to it, we could very well be that social capital, that meso level that Dr. Raj talked about, where we can help each other with early conversations, even on the telephone, helping one another navigate grief, which is such a terrible, desolate, and this is this desolate territory just scattered with debris of all kinds of tragedy, and provide support at a time when usual support systems are reeling. Normally, if someone is sad, they'll call a friend or they'll call another family member. But what happens when your friend is also going through this and your family member is also going through this? And that is something that is happening right now. Today, everybody knows somebody who is experiencing a loss or is really anxious about somebody's health. Now, leaning on them at a time like this becomes very, very difficult. So those of us who have the wherewithal, who have the ability to reach out to these people and be that support system, it becomes very important. And palliation, like Dr. Raj said, the addressing suffering, if there ever was a time for it, it is now. And of course, care for children. We're seeing so many terrible posts about children being orphaned where they've lost both their parents and all of that. But correct information at this point is also really important. Lots of very large-hearted people are saying, okay, if there's a child that needs to be fostered, I will do it. But that could also be a very dangerous thing, because what we saw after the tsunami, which happened a few years ago, one of the saddest outcomes was that a lot of children were abused and trafficked. So we as volunteers and we as community members need to actually propagate sensible and good information that will safeguard the well-being of those who are most vulnerable. And some of the most vulnerable people right now are little children. So just coming back to the Lancet article, which was published in 2020, and April 2020 suddenly feels so far away. But what it did say was to ensure a balanced supply of opioid medication, which is something that we use in palliative care a lot, to conduct rapid training for all medical personnel on palliative care for COVID-19 patients. At Pallium India, we have successfully run 26 batches that spanned 12 participants from 12 countries and gave them a 5-day basic training in palliative care approaches to the management of COVID-19. And let me tell you that 99% of those people had never encountered palliative care before. And the testimonials we received from them after they were able to apply those practices on the field were very, very heartwarming. And I don't just mean that in terms of symptom control and stuff, even just talking about distress, about communication, about having those conversations, all of that to a large extent. We had wonderful collaborators from different parts of the country and a group called Palliative Kerala who came together, and there's a resource toolkit that we put out. It's on our website, you can have a look at it. And that was something that was also endorsed by, the Lancet had also recommended that something like that would be useful. And of course, what we're seeing now is that we're engaging technology. Right now, that's what we're doing. We're engaging technology to talk to all of you. And to expand on telehealth capabilities. So there are the professionals who deliver telemedicine, but there are also grief helpline. There's a grief helpline that we run. and also so many other ways in which we can pitch in and just be available with our own expertise and resources to, I mean, that's what we're seeing right now. If you look at anyone's Facebook or Instagram or in Twitter posts, it's all about mobilizing oxygen, it's about mobilizing other forms of care, material supplies, etc. So we're seeing that happen. And the last thing is to also enable families to virtually visit and partake in health decisions. So these were some recommendations that had been made. I just want to quickly, before closing, talk about healthcare workers. And I don't, like I said, I don't just mean doctors and nurses, but everybody associated with healthcare right now are also experiencing a tremendous amount of suffering. And so now more than ever, we rely on our communities to keep us buoyant and to keep us going through, because there's a lot of vicarious suffering. When you witness so much suffering, no amount of training in being objective professionals can help. And your armor is going to be breached. There's a lot of disenfranchised grief. Disenfranchised grief is basically grief that is not recognized or is not given social acceptance. As a doctor or a nurse or a mental health provider, you are not allowed to feel grief over someone you've lost or somebody who's suffering. But that all those boundaries are being breached at the moment. Grief over their own relationships and multiple losses being experienced at the personal and professional level. A conflict of roles. A lot of people are having to be part of a system that does not align with their personal values, perhaps at this point. And also being a nurse and being a mother of 2 young children. I mean, which one do I need to do more? Where am I needed more? There's a lot of role conflict, and there's a lot of guilt that maybe I'll take the infection home. Maybe I'm not being a good mother by going out onto the field. Maybe I'm not doing enough here. So there's a lot of this plethora of emotions and suffering that even healthcare providers are going through. So we'll be sharing some of this learning material with you, but at the very end of it, some of the key ethical principles for optimal care during the COVID-19 pandemic. These are groups of organizations that are working globally in palliative care, and we have the good fortune of calling all of them our friends here at Pallium India. They talk about the key ethical principles of non-abandonment, respect for persons, autonomy, reciprocity, confidentiality, whole person care, justice and fairness. And all of these key ethical principles are key ethical principles of palliative care. So relevant now more than ever. So I'll end with this quote, and Rachel Coulin and Moira Leng are again colleagues of ours. And this was a letter that they wrote to the Lancet, where they also talked about suffering and illness and dying reminds us of the universal truth of our mortality and humanity. And palliative care is rooted in the recognition of our common suffering in illness and dying, and our compassionate response to suffering and our shared humanity. So fundamentally, palliative care seeks to ease suffering and uphold dignity. And that is why palliative care today, now more than ever, is a very, very appropriate and needed response to the context that we all live in. So I will stop with that. Dr. Raj, I know we're out of time, but if everyone's okay with taking a few extra minutes, we can take some questions. Dr. Raj, you're muted.
Is this the time to ask questions?
Yes, please, Abhijit.
Okay. How would you describe is the global awareness for palliative care among the Western countries, especially, and if it is something which is already recognized and accepted, then why is not World Health Organization compelling the other countries, other nations like India to execute palliative care right down on the grassroots level? Where is the block in that process?
I don't know if Dr. Raj is still on this call. Raju?
No, ma'am. I think he
Okay.
accidentally
Okay. He would have been the ideal person. Okay, I'll try my best. It is recognized in several Western countries, what we call the global north. So you'd find that in Western Europe, it's part and parcel of the healthcare system, as it is in the US and so on. It is not a, I would say that the awareness in low and middle income countries especially is very poor. In India alone, less than 2% of our population has access to palliative care. And there are recommendations. The UN or the WHO can only give recommendations. They cannot compel any country to, Dr. Raj is back. Dr. Raj, can you hear us? You're on mute, sorry.
Sorry, Smriti, I got disconnected. Please continue and wind up because I know that times.
No, Dr. Raj, the question was why is palliative care, it exists in other countries. I'm just paraphrasing Abhijit. Abhijit, actually, why don't you just ask Dr. Raj that question?
Yeah, what I was saying is that if palliative care is so well received in some of the leading nations, and even World Health Organization has recommended it or endorses it, then why is it not pushed in countries like ours, in the developing nations like ours, right down on the level of on the grassroots level? That, I mean, where is the block there? What are the, that's the question.
Abhijit, people like us have not been effective enough as advocates. This is true for most of the developing world. And even for very affluent countries in the Middle East, they have very little palliative care. The high income countries, except Middle East, generally have palliative care. But low middle income countries do not have. And therefore, we are slower to change. Our management systems in the government and machinery are less efficient. These are some things that we have to live with. Therefore, unless we are loud enough as advocates, effective enough, things will take a lot of time to change. But having said that, Abhijit, National Health Policy 2017 does include palliative care. Some changes in the law regarding opioid medicines has already been effected. As we speak now, during the last 3 months, primary care workers all over the country are being trained in palliative care. Some positive things are happening, but at tertiary levels, corporate hospitals, it's practically missing. And we need to be more effective advocates.
Right. Thank you, sir. Thank you, ma'am.
If I may add to that, I think a very important component, and that's where we need to work together, is demand generation. So one is to bring it to the attention of the decision makers and the policy makers and all of that, but also to spread the message in our own communities that this is something that is your right and you should ask for it. And demand generation would also then aid quite a bit in moving things along.
Right. If I may just ask about some of the leading hospitals like Apollo, Fortis, do they have palliative care? I mean, these are supposed to be multinational, multi-specialty hospitals.
Very few of them have. Most of them do not.
All right. Thank you.
Sorry, we're well over time, and I know that everyone's been here for over 2 hours. So please do make a note of your questions. We're very happy to address them. You can email them to Rajlakshmi, and we'll try and make sure that we answer all your questions over the course of the next few days. Abhijit, you flagged some very important points, which we will try and also weave into our coming sessions.
And I think Raju will want the feedback, wouldn't you?
Yes, sir. We have shared a feedback link. Just click on the link and do the feedback. This is solely for today's session. We'll be having this feedback for all the 5 sessions coming forward. So I think it's time for us to wind up. Thank you, Dr. Rajagopal and Smriti ma'am, for that wonderful explanatory session. So we can see you tomorrow with a session on home-based care taken by Sister Stella. Same time, 5 to 7 p.m. Bye till then. Thank you.
Thank you, everyone.
Bye-bye.
Thank you. Bye-bye.